Hello and welcome to Retina Connect. This is a program of events dedicated to sharing and discussing practical surgical experience. Today's episode is on surgical dilemmas. What would you do? And I'd like to welcome our panelists this evening. We have Gaurav Shah of West Coast Retina, Mike Jumper of West Coast Retina, and Dean Eliott of Mass Eye and Ear. Without further ado, Dr. Shah.
Monica, thank you. And I want to thank my colleague and partner, Mike Jumper, and then Dean Eliott, a friend and colleague and a partner in life for all of us. So I'm going to get started. Hopefully, Monica, let me know if you guys can see my screen in just a second. Okay, can you see Monica?
Yeah, very good.
Okay, sounds good. Okay, so this is Dean and Mike, the dual lens case. And again, for all the lens fanatics out there, we're not going to show how to put lenses in, but how to take them out. So this is an IOL, AC IOL, and a PC IOL. Dean, how do you do something like this?
Well, it's interesting that you have two lenses in the eye in the first place. That's not really supposed to happen. So somebody left the IOL that was dislocated posteriorly, and then they put in an AC IOL?
Exactly. This is the world we live in today, Dean. Everybody's busy. Just put it in.
Well, I don't think you see twice as well with two lenses, so I would take one of them out. I would probably either take it out at the limbus in a normal situation, but since you have an AC IOL and a dislocated PCIOL, you want to get the PCIOL out, and I would do that at the pars plana most likely, and leave the AC IOL in place.
Exactly. Dr. Eliott is a smart guy. So what we did with this gentleman, these were actually two cases. This is another case. So this we have a video, but very similar. You can see the wound. Now, these are MST scissors that you can actually use to cut the lens out. And I make a shelved incision, do our standard sort of vitrectomy, put in the trocars, and then actually at the one edge of the shelved incision, put another trocar in. So we're ready to go when we can take the lens out. And the wound was having some issues here, so the fellow's putting sutures in. Despite all of that, it was still kind of leaking a little bit, so I put this Resure sealant that works pretty well. So once this is solved, we go inside the eye, and again, AC IOL. So as Dean said, we didn't want to do anything in the AC. We use these MST scissors, enlarge our incision slightly, and take the residual material around the lens, hold that with the forceps on one hand, and then actually use the scissors with the other hand, cut the lens. And I actually wanted him to cut it just not all the way through, and then sort of get it where none of the pieces actually are small. But before I could say that, that happened. So now we just take three pieces out. But again, kind of showing an approach to the pars plana, and that works pretty well. Our incision's not very big, and you can easily pull this out. So Mike, any comments on this before we go to the next case?
Just a quick question. So the corneal wound was the original wound that the surgeon had used, the one that you have sewn up?
Exactly. And okay. The problem is that this guy's endothelial outcome was very poor when we actually did it before the surgery.
I see. So, yeah.
Anyway, just a good MST scissors.
I think that I think the good points of this, that you'd kind of shelved that scleral incision a little bit. Is that what you did to kind of help? Yeah, I think that that's a good technique, because a big old scleral incision like that can sometimes be difficult to get closed, and so any kind of shelving can maybe aid in getting that closed. I would typically close it with like Vicryl suture. I don't know what you closed it with, but I think that it closes pretty well with Vicryl.
Yeah, that's what I did. And again, I think the high flow infusion cannula makes a difference. So this was another case that was sent to me that was just at a dislocated IOL. But when we looked at him in the office, he had more than an IOL. So I like chandeliers for these cases. And so he had a dislocated IOL and a Macular ring. And same approach, shelved incision, bring it up to the AC, bring it up in the posterior pole, remove the stuff around the lens. You can see the whole complex has dislocated, and here's the Macular ring. These are, quite large. So same approach, cutting it one piece, 3 pieces, and then we removed them, and then along with the IOL. So Dean, any comments before we go to the next case? But similar cases, but the Malyugin ring was a new one for me.
Yeah, I've only had to remove a Malyugin once. It was a really long time ago, and it was dislocated by itself. So sometimes they're a little hard to remove because they're so long and they're curved. If you grab it, looks like you grabbed it in the middle, but because you had a big wound. But when it's
Exactly.
only a Malyugin ring, you have a small incision. You have to grab it like at the end, and it's actually not that easy. But I
Got
love
it.
your
Okay.
wound. I like the biplanar wound. That's good.
So this is a quick one. If there's not too many comments, we can move to the next one. But this is somebody with a macular hole and a retinal detachment. And typically, I'd like to make a large flap, but these sometimes are, it's not as easy in a total detachment with a macular hole. So what I did was I made some kind of petals, both from superior and inferior. And you can do this under PFO, but I actually kind of find it to be harder under PFO. So I kind of like this, using blue, making flaps, and then not doing really anything special for the detachment, but obviously not draining through the hole, draining through a retinotomy site or the break, peripheral break, and then doing air fluid exchange. You can see the blue where the flaps are and the hole closed, and the detachment did fine. So Dean, any quick comments on that one?
Yeah, it's hard to peel an ILM when the retina is detached. And one thing that helps is if you peel in the papillomacular bundle first, which is what we typically don't do. You peel towards the hole. This way, the disc is a fixation point that's kind of holding your retina in place. Retina doesn't flap around as much. Do you do that, or
Yeah, I do, Dean. I think sometimes you just have to peel, let the retina relax, and start again. Peel and let the retina relax and start again. So I think sometimes, just the fluidics in the eye, you have to kind of have it help you.
I really
Dr.
worry
Shah,
in that.
I'm
Go
sorry,
ahead,
there
Mo.
was a question on that first case. I just wanted to highlight the question that was submitted on the first case. You were asked, how did you illuminate the vitreous cavity in the first case? It was mentioned that we didn't see a chandelier. You were using bimanual technique to cut the IOL.
You know what? I don't want to go back.
Well, in that case, that was coaxial. That was coaxial illumination. So he was looking just to the scope.
Okay.
All right. So this is one that unfortunately all of us who train fellows have faced. So this was a buccal vitrectomy, and you can see subretinal blood. So Mike, what do you think about?
Yeah, well, anytime that you're doing the buccal vit, and so you put sutures in the sclera, it's very easy to get a suture through and through that can cause you to have blood both under the retina in the vitreous cavity and have choroidal bleeding. And so it looks like, that was a through and through tear, through and through pass with the needle. And what I tend to do with those is you first want to make sure that you don't have any incarceration of vitreous in that wound. I oftentimes will cut the suture that was there, but I don't take it out immediately because I use it as a marker, and I move the buccal back a little bit so that I'm supporting that break. And then I replace the suture, hopefully not through and through again. And then I treat it like another tear in the detachment. But I like supporting those. I don't know that it's that big a deal. I think it's a big deal when you're doing a buccal alone, but it may not be that big of a deal in this situation.
Yep, and that's exactly what we did. And one little caveat is when you do that buccal vitrectomy, make sure that when you don't have any choroidals when you're putting your infusion in. So, because sometimes the eye will get soft. So this is, Dean, a case that was being done, a TPA case, and where somebody was manually injecting the TPA. This was a case that was sent to me, and you can see the TPA going in nicely. And as the TPA goes in, you'll see the state of Hawaii happening here, where there's a volcano. And now you got right there. So Dean, how do you manage? What's your goal for management for this?
So it looks like you were injecting in the subretinal space, and whoever pushed the plunger might have pushed it a little too rapidly. So first of all, before I push the plunger in these cases, I do lower the IOP because there's a lot of resistance in the subretinal space. And if you have a pressure of 20 or 25, it's actually, you have to push harder and you're more likely to get this blowout. So if you lower the IOP to like 5 or 10, it's a little bit easier to raise the retina. But since you told me you were going to show a case like this, I brought a little syringe. So when you're the assistant and you're pressing the plunger, you do not do it this way. I never press in the eye like that, because as you know, plungers sometimes get stuck and they can shoot you can press a little too hard. So if I'm the assistant and I'm putting some TPA in, I actually hold the syringe like this. You inch the plunger forward so that you can't push too hard in one shot, because you're moving it very, very gradually. That's not always as easy as it sounds, but I think if you lower the pressure and do it as gently as possible, you'll avoid this.
Well,
Another
and I-
caveat to that is
Go ahead,
that
Mike.
when you're pushing in, no matter how you push in, if you twist a little bit, that seems to kind of break up that traction, the friction between the plunger and the inside of the cannula, that you can kind of, if you just twist a little bit as you're plunging, that can help as well. That's one thing I was taught. And I don't do it that much because I never inject anything like this. If I were to do something subretinal like this, I would use the machine to help me kind of gradually inject under the retina, and not do it with I think the machine does a better job. And then we'll talk more about other methods for getting things in the eye. But I think
Exactly.
using a machine for the subretinal is probably the way to go.
Yeah, and again, this is not mine. This was sent. So I always use the machine.
Yeah, machine is
Okay.
definitely.
And now with the new Nexus, we'll have already a setup to begin with. So here's a quick case, somebody who has a multifocal IOL, ophthalmologist's mom who is kind of miserable, and you can see anterior vitreous that is on top of the IOL. It's always sometimes kind of struggle, what's the best approach? So we do 27 gauge vitrectomy, and then I put in blue, so it highlights the vitreous quite nicely. And you can use Kenalog too, but it's just a blue works. And then we put a 27 gauge cutter on the flow mode, very slow on the EVA at maybe 1 or 2 cc's. You can see the chamber doesn't shallow. You've got the infusion that's running from the posterior pole, but you can see the cutter into the AC, and this kind of works nicely with this technique. Once this is done, it's almost self-sealing. We just hydrate the wound, and then we're done. So and you can see now you get a crystal clear view with the multifocal they put in this patient. So Dean, any comments? And Mike, before we go to the next one?
I like this. I've always used Kenalog and it gets all over the place, which is a little bit of a mess. This is really neat. I'm going to try this. Thanks.
Yeah,
All right,
same
thank
with
you.
me. I think it's great.
Okay, so next case is what Mike and I were talking about. Is this is a case that was sent to me by one of my colleagues from overseas. So first problem is the soft tip falls into the eye during a macular pucker case. So they have to now remove the soft tip cannula. So once that is removed, you think your day is over and things will go well. And now as they're doing a job peeling an epiretinal membrane, significant, vitreomacular traction, tight hyaloid, whatever you call it, but that's not the issue with this case. But this just shows the macular pucker being peeled. Again, nicely done. There's nothing here that's a problem. Once the pucker's peeled, now they're looking for the ILM, and this is what happens, the stream. Bingo. Mike, what do you think happened there?
I think this was just a manual injection that was too high a pressure, and it's the same thing. A stopper in a syringe can really, have a great deal of friction that you have to overcome with a lot of pressure in order to make the stream go into the eye. And that stream is so extreme that it can perforate the retina very easily. I've seen this happen.
And the other thing, Mike, is anytime you inject anything in the eye, just inject it outside the eye first, right?
Absolutely.
Whatever you do.
One other
Okay,
point,
so
Gaurav. So
go ahead, Mike. Go ahead, Dean.
your instrument seemed a bit close to the retina. So, you should obviously start injecting with the instrument kind of retracted back toward the sclerotomies, but also you could take the other instrument sometimes. If I have an assistant who's very inexperienced, I'll obviously have the instrument close to the sclerotomies, and then I'll take the other instrument and put it in front of it. So that
Exactly, like a shield,
if they inject too hard, it's being dispersed by the other instrument. won't hit
Right.
the.
So I think this person sent it to me and, felt terrible this happened, but I said, I think this is a good learning thing for all of us. So this is an issue that comes up with silicone IOLs and silicone. This was a patient that was sent to me, and this video is actually on the Academy's video series, but this shows there's oil in front of the lens and oil behind the lens. So I have now using a finesse loop that actually does a nice job of actually removing the oil behind the lens. And there's also some oil in the front of the eye. You can see we're using some BSS, kind of try to break that up. And then eventually we also put the finesse loop into the AC as well, as you'll see. But this does a nice job of actually, there you can see the finesse loop, and makes it manageable to then go back and forth with some BSS, finesse loop, BSS, multiple air fluid exchanges, but then you have a fairly clear lens. And you can see from what we started to now. So it's just a nice technique. And this was sent to me for an IOL exchange, and we didn't do anything except this and then multiple air fluid exchanges. Dean and Mike, any comments?
Well, I've learned another thing. I haven't used that before. What I usually do is the power wash. So I fill the eye half of air. You do a few fluid air exchanges, like you said, but you can have the eye half filled with air and attach a syringe to the vitrector full of fluid, and you put the vitrector right behind the IOL, and the assistant presses the plunger. Now, in this case, you want to press the plunger hard, and it sprays the fluid onto the back of the IOL, and it's like a power wash, right? It disperses all the little droplets. They fall back, you skim them off, and you do it over and over again. But it looked like you got all of the droplets, whereas the technique doesn't always get them.
And that's what I was frustrated with that technique, and I did the same thing, but I would still see droplets, right? And so anyway, I thought it was a nice technique. So anyway, we will get to this case. I want to leave at 6:20, and we all want to make sure everybody has enough time. So I'm going to stop sharing now, and if we have time, we'll go back to this case. So Mike, I'm going to stop sharing if you want to take over.
Yeah, and there was a comment or a question earlier, Dean, about, do you think it's safe to peel in the papillomacular bundle like you had talked about for a case where you've got a detachment you want to peel? And I just will let you answer that as I'm pulling up my cases.
I think if you're an experienced ILM peeler, yes. I think when you're starting out, it's probably not the best place to do it. So remember, I don't normally start in the papillomacular bundle in an attached retina. I only do it in these cases where it's detached. But I would not be doing it if you're not, at that point, pretty good at peeling the ILM. What do you guys think? Do you guys do that at all?
Same exact, Dean. You got to just you got to find the ILM and kind of make it do. But you're right, it's not the place to start. But really, in the detached retina, you just have to figure out what tractional or tangent component works well for you.
All right. Well, I'm going to show some cases of Dean and mine, and I'll get started here. So this is a case that happened just last month. And this is the kind of the setup picture. This is a diabetic who's got progressive, really bad PDR and developed some progressive traction. He got PRP. This is post PRP. He's developing traction, and then he shows up with a vitreous hemorrhage that we took care of just a few weeks ago. And this video is just of us finishing up the vitrectomy, and I'll just show you something that happened. So. By the way, I want to say the fellow had done the majority of this delamination. Everything was excellent. I took over to take a little bit of the delamination off the superior temporal arcade, and now there's a little bit of blood on the surface of the retina. I'm clearing up, and you'll see there's some movement happening, and this guy thrashes about on the bed. His head is taped, but he thrashes about on the bed, and all of a sudden, boom. And unfortunately, the video is a little bit stuttery, but there's a time where the first thing I do is I stamp on the 60 millimeters of mercury, and I'm showing the video of him, kind of under the scope with the lights off, but the guy is just thrashing about, and don't have good video. There it is. That's the kind of movement he does. And I think there's one type of movement I think is very dangerous. It's when somebody goes one way and then whips back the other. So now this is after I've gotten back into the eye, and I see that there's blood both underneath and in the retina, and I see that it's bleeding. And I don't think it's retinal bleeding, I think it's choroidal bleeding. And it turns out that was it. And the pressure is extremely high. And I've got a lot of, it's a closed system, but I'm having a hard time getting this choroidal bleeding to stop. And I'm concerned about putting perfluoride in at this point, although that's an option. But I end up taking blood out from underneath the retina. You can see there a big clot of blood. Now we're still kind of away from the fovea, and so I still have hope that there's going to be something salvageable here. And so, but after I get the blood out, I'm able to get to the choroidal bleeding with the diathermy, and we get the diathermy to kind of calm this down. I go back a couple more times and aspirate some blood that has reaccumulated underneath the retina around this tear that I created with the cutter when he moved about. Now I feel like things are under better control. I put perfluoride in order to sort of flatten things out around there, and hopefully prevent, squeegee any blood that's gotten closer to the fovea away. And he's you can see here, he's stopped bleeding. The pressure's, I'm able to get the pressure down. I laser around this. I laser in the bed of this. And then I finish up the PRP and we are done. So any comments on this kind of case?
Mike, I mean, you handle it beautifully in a bad situation. I think this again goes to the notion you got to be careful when you tell anesthesia, hey, try to get the guy calmed down. Sometimes the anesthetics they use, it just makes it worse. So you got to be careful with that. And I think it's also a good lesson for the fellows that anytime you take your away from the eye, never leave instruments in the eye. When they're passing things, the light pipe might slip in the eye and they're doing something, and it's a big problem. You got to take the instruments out of the eye, unless you're looking at it. So
at the end of the case, this is a question from the audience. I did use C3F8 gas. There was an issue, the possibility of him getting silicone oil, but I didn't feel like that was necessary at the end. And I thought the C3F8 would be fine. And so that's what I used in his case. But it's a question whether or not, silicone oil would have been useful. I think if I had a harder time getting the blood to stop, I might have.
So Mike, there's an interesting paper by Colin McCannell that if you fall asleep, you're more likely to wake up and jerk your head. So whenever a patient starts snoring, I always ask the fellow, I say, patient is snoring, what does that mean? The incorrect answer is patient is asleep. Well, obviously, if you're snoring, that you're asleep. But what the surgeon should be noticing is when the patient's snoring, that is a risk that they're going to suddenly jerk their head. So sometimes when you're doing delicate maneuvers and you start hearing the snore, you tell the patient to wake up. We're doing important things. Please try to stay awake. Because the patient sleeping before it happened, or did he just decide to thrash?
I don't really remember it. I mean, he wasn't snoring. He may have been sleeping that I didn't know about. But I'll tell you, I have a lower threshold for young men to kind of have them under general anesthesia than I used to. Because I think that young men, and this guy was in his maybe 50s, that it's just one of those scary situations where I think that they are more liable to move and thrash about than anybody else.
Mike, it's our rule. I think all of us are, I guess, in our 50s and young. We would be the worst patients. So I think all of us should be put to sleep for whatever happens. But that is a bad age group to do. And going back to Dean's point, I think you got to be careful when you're snoring. And when you hear them from not snoring, that's even worse, because now they're in the in-between zone, Dean, of just getting awake and not knowing where they are.
And even worse is when the fellow starts snoring.
That's pretty good. All right, so this next case, this is a case just for discussion. This is not a common thing. But this is a 20-year-old who came to me about 3 or 4 months ago who has a history of ptysis in his left eye. He has a very positive family history of blindness, and he comes in looking like this with a lot of exudate and detachment, especially out nasally. And you can see out here, these vessels are a little suspicious. There's a little something suspicious looking here. And this is a case of von Hippel-Lindau. And he has 3 big retinal capillary hemangiomas in the periphery of his eye. And there's a lot of traction. There's traction detachment, but there's just a lot of traction. I think this is just his other eye is testicle from the same reason. He had moved from the Philippines. And you can see here just this general quenching type thing, but bad leakage in those areas where he had the hemangiomas. He had a couple other small ones as well. So this is just a video of the 2 cases that I did on him because he ended up, we did a vitrectomy and we tried to relieve as much traction that was happening. And you can see here I'm kind of cutting some vitreous bands, and you'll see me peeling some fibrotic kind of organized vitreous bands in epiretinal membrane up to the area. I have placed a buckle because I'm hoping to support those areas where he had the hemangiomas. I'm trying to get as much vitreous off. He's phakic at this point. And this is me doing basically like a triple freeze thaw with cryotherapy. And you can see the change in the vessels, at least we could intraoperatively, that things kind of quieted down as far as the vasculature goes. I then also placed laser on these hemangiomas. And so I'm just trying to destroy the hemangiomas as well as this little hemangioma that you can see there that I saw on fluorescein angiography. I'm also placing some laser on the buccal. So these are kind of continuous spot lasers that I'm placing with the lighted laser probe to help me kind of best see these hemangiomas in this phakic patient. So that's just any comments on this while we kind of rewatch, but any comments?
Mike, these are difficult cases because you've got blood, you've got subretinal fluid, and these are just at high risk for proliferation, even no matter what you do, a buccal, laser, cryo. There's so much traction and so much vascularity. It's a problem. I'd be curious to see sort of, how this guy does, but I think it's a problem.
Yeah, so 10 days later, he was doing okay, but 10 days later, he develops a new shadow and he's detaching. And I wasn't surprised, and I had prepared him for that. So this time, you just got to go full Monty. And so I do a lensectomy, which we will speed through. And now I decided I was going to leave the anterior capsule on this guy, hoping to be able to just slip a sulcus IOL at some point. I just needed to get access to these different hemangiomas. Now they look really quite quiescent at this point, and I was able to basically just cut them out, which made things easier. I did diathermy around them and then just basically kind of removed them with a vitrectomy cutter. So now I have 3 areas of focal retinotomy. But had I tried to do this when 10 days prior, when they were kind of flowing hemangiomas, I think it would have turned out pretty bad. And so I think that this is kind of thinking that you're going to do this in a staged manner is a good way to be. Now he's one-eyed. I'm able to get the retina reattached. I laser these places down and I put oil in his eye. And so that was the plan on this guy. Any comments?
Yeah, the feeder vessel never oozed later?
No, not in the re-op, no.
That is amazing. Wow.
Yeah.
That's just 10 days. I really think, in fact, even during the case, the feeder vessels were sort of like kind of going the first case. And then when I got to the second case, there were it wasn't obvious. Those vessels did not look like obvious feeder vessels. Wow. So the other point I want to bring out in this case is that if this exudate that you see here was in the fovea, I would be treating this guy with serial anti-VEGF injections, because I think that this is the cause in people who have Coates disease or any exudative lesion to cause them to have a fibrovascular nodule in their fovea. And he might get one, but it won't be in his fovea. And so we're watching that. And I might consider, when we take the oil out, I might consider anti-VEGF injections if this doesn't start breaking up. But that is a big worry to me, this exudate under the macula, because I do think that can lead to fibrovascular, kind of like almost a type 3 choroidal neovascularization.
So Mike, that was going to be my question to you, is about the anti-VEGF. So I'm glad you brought that up.
Yeah.
That's a beautiful
I don't,
result.
I, go ahead, Dean.
That's a beautiful result. These are really tough cases. I do agree with you about the lipid in the fovea, but this is
Yeah.
outstanding.
Well, it's a good result because it's very early, and I'm going to move to St. Louis so that just like Gaurav moved to California, so that we can kind of make sure that leave these at a good stage. All right, let's do one more of mine here. This is a 60-year-old patient who's a diabetic who has, I think, the worst situation of PVR, PDR, and this patient ended up having a total detachment that I've just peeled a bunch of traction off of the macula from the PVR. And now I've decided in order to get the retina flat, I'm going to have to do a retinotomy here in the very back of the eye. This is that postage stamp type thing. But you can see here, there's a very bad macular hole, a very large macular hole. And this is, I did this some months after Tamer Mahmood had showed and introduced the idea of using a retinal transplant, autologous retina, to try to close holes. So I thought this was a good case to try this. And so I've got some diathermy to mark the edges of this area that I'm taking. This is going to be retinectomy anyway. And so this is retina that I don't have a whole lot of faith is going to provide great vision, but I think it might get the hole to close and help the eye. So I've taken this piece and I've unrolled the retina. So I flapped the retina over and I put this piece in the macula under the hole. And it's a large piece of retina and it's on the underside of the retina now that I'm trying to get to sort of get under the macula and under the macular hole. And now I'm rolling out the retina and putting perfluorine in. So the thing that was interesting, go ahead.
Mike, that they made it look easy, but there's a little bit of a challenge there. Once the retina is flipped over and making sure that little piece stays where it needs to be. Was that difficult, or it just happened to just stay there by magic?
It was a big, I think one of the reasons that it worked at all was it is a bigger piece of retina, and it was not totally centered under the hole, but it was eccentrically placed such that it was under the hole. And so now I'm this is post-op day 1, and you know, vision's hand motion. This is post-op week 1, and the thing that's fascinating to me, and it's been shown in other cases, but this is, look how this is 2 weeks later, look how the configuration is sort of changed and get a little bit of epiretinal membrane formation, but the hole remains closed and the vision is way better than I thought it would be. So anyway, I just thought that that was a cool case to share. Let's see here. We've got,
well, and Mike, I think, again, I want to comment on Mike's technique. You know, he also did this without the chandeliers, right? So he was just doing this with, so you can spend a lot of money and that's great. But again, and chandeliers are great too, but this is, again, a great way for people to learn. You can do this even without it. So kudos, Mike.
So Dr. Alisil has just asked a question, you know, how about amniotic membrane for this kind of a case? And I don't have much experience with amniotic membrane, but it seems like, you know, that's any, you know, when you're trying to get the hole to close and trying to keep the retina attached, it seems like a reasonable thing to try as well. You know, because of the fact that this patient needed a relaxing retinotomy anyway, it was, you know, I used this.
I think it's a great thing. The amniotic membrane is, you know, it's you have to have it, right? You've got retina there that's not going to be good, so this is a great use for it.
You know, we've seen a lot of these cases presented. That is one of the most compelling cases in support of this procedure. That really looks like a great OCT and better vision than expected. That's wonderful.
Magic.
So this is a quick case. It's a woman who's just developing progressive traction and vitreomacular traction, which has gotten to be really quite extreme, where there's an outer break of the retina and the vision's gotten to like 20/160. And so the thing that we take her to the operating room, and the thing that I wanted to bring out is the fact that, you know, we did a 27 gauge vitrectomy. I did membrane peeling, and the thing that I thought was very interesting, it was like one of the times that I really thought that intraoperative OCT could be helpful. So I go through this, you know, the entire macula, and I do a lot of imaging just to try to make sure that I don't have any breaks after I've peeled. And because you can imagine that'd be a pretty easy way to make a macular hole. And then, I was just thinking I'll put gas in. But because I had done this OCT and kind of felt confident that there was no breaks, I decided not to use gas. So this is how the patient looks here 2 weeks post-op. And this is how they will look 12 months post-op, a year later. And then it was 19 months before that macular hole, that subretinal fluid kind of subsided. And there was certainly some pigment disruption and changes in the outer retina. But it was I thought it was an interesting case, but it does highlight how long it can take for this fluid to go away. And I don't know the answer if whether or not, putting gas in at the time would have helped much. I think what it does is that it does displace the fluid a little bit more. I'm sure that's pretty thick fluid that's under the retina, and it might displace it over a larger area of RPE that might help resorb it slightly better. But I wouldn't be surprised if it wouldn't take that long, or about almost as long, even if I'd have put a gas bubble in. Any comments?
I think you're right about that. Gas made a difference, but I am always amazed at the variability of the rate of subretinal fluid absorption, right? I mean, you would have expected this to be gone a lot sooner. It's amazing. Patient still did well.
Yeah, and the choroid, isn't like, I would think sometimes in a high myope, the choroid's super thin. I don't know. I feel like their RPE might be as sick or something. This wasn't the case for her. So I don't know the answer either. I agree.
And Mike, look at how the architecture, right? It looks like the ellipsoid zone. I mean, it all looks great, right? So I think with fluid, sometimes you just have to wait and it will go away. It will go away.
All right, Dean, got a case for you here. Let's see here. Let's look at which case this is. Okay.
Okay,
so I'm gonna start running the video.
Yep, just play the whole video start to end. So this patient had surgery.
Oh, sorry. Hold on one sec. I moved it and it, let me turn off.
Yep.
Okay, now we go.
This patient had surgery elsewhere for a giant retinal tear. Here you see the pre-op appearance. They fixed the tear and you'll see the post-op appearance here. Patient has a cataract. You can't see it too well. You'll see it better in a moment. There's a few folds in the macula. Now this patient was sent to me 4 months after the surgery. Now you see intra-op, you see those 2 massive folds. So if you want, you can stop it and you guys could just tell me what you would do. First of all, would you even operate 4 months post-operatively? You think it's futile? Patient was
nice.
really bothered by distortion. So that was my rationale. But what do you guys
nice, Dean. It would be nice, Dean, to have this guy earlier. We got good at this during the translocation days. But I think if the patients, this isn't a mild fold, what you're showing. This is somebody, he probably drew it out for you. This is what I'm seeing. Because that's usually what they do. They'll draw it out for you. So yeah, I would do surgery offer knowing that it's not going to be easy to have a fold that's now really fixed.
Mike, this guy walked around with a patch because he said the distortion was just unbearable.
Yeah, I think that this is something needs doing, but I can tell you it's going to be hard when, as easily as we can make detachments happen intra-op sometimes, it is very hard, it seems to me, to make them happen when you want them to happen. And so, I think that you've got to get this retina loosened up and one of the things is it looks like the fovea is pretty much displaced, and wrinkled up. And so, you've got to do something to get that retina loosened up and moved over. And I think it's going to take a lot of maneuvers. So let's see.
The other challenge here is not, sometimes you'll have this, but you've got retina that's tacked down 360 degrees, right? That's another problem.
Correct.
Yeah. So one thing else I wanted to point out was that, let's see here, that you have a big tear out there temporally, right?
Yeah, it's tacked down, but there's an old tear. Yep.
Yeah. So, I mean, you've got a retinotomy in the waiting.
Yeah. So this video was edited by Patrick Olars when he was a fellow. He's now in Syracuse, New York. So you're seeing we're making blebs to detach the macula area, the area around both of the big folds. We're getting really good blebs here. But as you'll see, the retina had so much memory. Those folds were really stuck. We were hoping to just displace the folds out to the periphery, but we couldn't. So this obviously slipped because of retinal redundancy. I think most of us are familiar with that concept. It happens with GRTs. And basically what we ended up having to do, since we couldn't displace it, is we cut the edge of the GRT open again. So just posterior to where the laser was, we recreated a GRT. And then as you'll see, we then steamrolled we tried to peel some subretinal membranes as well. There were a few tiny ones, but not much. And then we put in perfluorocarbon and we tried to steamroll those folds out. You can still see the folds, they have so much memory that now I'm taking a soft tip cannula and basically stroking them to push the fluid out and try to flatten it as much as possible. And that took a while with the perfluorocarbon in the eye. Eventually we tacked down the GRT again and remove all the fluid. And you'll see the patient actually looked pretty good. Right here, you see it's nice and flat. Okay, you can end the video. But the patient did okay. Vision didn't improve too much, but improved a bit, and he wasn't bothered by the distortion. So that was the most important thing. Okay.
And Dean, these people are miserable. I had people who would literally in a piece of paper draw it out for you, say, I see this. I see this big line in my vision. I mean, they're really miserable. So even though you didn't help, like in terms of his Snellen, but I think the guy was grateful that you did this for him. So at least he doesn't have to walk around with a patch.
Yeah, believe it or not, I think he got to 2080 and he came in at 2400 or 300, and he was.
I mean, that's a great save.
Took a while. I mean, we had to get the oil out and all that. Anyway,
I think it's worth pointing out. I think it's worth pointing out just quickly that the way to not to deal with this really is to avoid it from happening, as you were saying. And I think that the concepts around keeping the retina without slipping when you're dealing with a giant tear case is very important. And I think the very important thing that I have tried to stress to the fellows is that you go very slowly if you're going to put in perfluorocarbon and then do a fluid air exchange, you go very slowly with that fluid air exchange such that you're drying at the edge of the tear all the way around, and you're making sure you've got just an air perfluorocarbon mix in the eye before you start taking perfluorocarbon out. If you have a lot of BSS or infusion fluid still in the eye, that's when this happens. And so you got to be very meticulous at the edge of the perfluorocarbon to make sure all that fluid's out of there. And if you can do that, I think you can avoid this.
So Mike and Dean, if you guys use oil, I mean, I should just avoid. I go PFO to oil. Do you guys do that, or you go to air and then oil?
I go to air now. I did the PFO to oil years ago, and I now do air. Either one is fine, but I like the air better because sometimes with the oil, it's a little hard to see the interface. You're obviously doing it a lot, so you're more accustomed to it. I don't know, Mike, you doing PFO to oil?
I do more go to air. It's just how I was trained. I do think that the direct PFO or the direct oil PFO exchange is a good one. But I think it's also a volume dependent process and not a pressure dependent process. So it's easy to get the pressure super high when you're infusing silicone oil, and you got to be very careful, watch the nerve. But I think it can be a good process. Yeah.
So one reason this patient had reasonable visual acuity is probably because, as you noted at the beginning, Mike, that fovea was not involved in the fold, right? The fovea was still getting nourished all those 4 months when the retina was attached with the folds. Had the fovea been in the folds, I think it would have not improved at all in visual acuity. You can go to the next case. All right, so this is a crazy story. This guy was shot at close range with a shotgun. He's a gang member. His other eye is no light perception. He had a few operations in this eye before he was sent to me. The other eye also had a few operations, and this eye is light perception. And we're putting in perfluorocarbon now after a long procedure of peeling preretinal and subretinal membranes. You see there's an enormous retinectomy. He didn't have much retina to begin with. I don't actually think I did any more retinectomy than what he came with. But as we're trying to remove the perfluorocarbon, we can't see. Stop the video for a sec. And we can't see because of this. So anybody know what's happening here? We were doing a fluid air exchange, trying to get out the perfluorocarbon liquid after we spent a long time peeling and flattening. And
he's aphakic at this point?
He is aphakic, yep, on one of the earlier operations, yep.
And then fusion's set at what, or where's the cannula, or?
Fusion's normal, so basically he's got condensation of perfluorocarbon on the back of his cornea, which is really rare. I've actually only seen it a couple times. We once published a photo essay of the same thing, but I mean, I've been paying attention for years since then. We haven't seen it really at all, hardly at all. So for whatever reason, he's got corneal endothelial perfluorocarbon condensation. So the normal thing, you can advance the video, start again, is we use viscoelastic. So what do you guys use when you get, let's say, condensation on the back of an IOL? Just keep the video running. What viscoelastic do you use?
Go ahead, Mike.
You know, we tend to use Helon, or I really don't.
Stop it here. Stop it.
Yeah.
I think, Dean, you know, there's a cohesive and a dispersive visco, you know, I mean, so you want to, I typically end up using the kind of the cohesive, it seems to work better.
I like the Provisc for when I'm coating back of IOL. So I use Provisc in this, but we then tried to remove the remaining fluid and the view got cloudy again. Basically the same thing happened. So here's again, so do you have any other techniques to solve this problem, since the Provisc really didn't work for more than a few seconds?
And you got the IOL there?
No, the no IOL, aphakic.
Not the IOL, but
It's the air bubble that's now in the AC. It's hard to tell. It looks like the condensation is on an IOL. It's not. It's on the back of the cornea.
So Dean, how do you know it's perfluoron? I'm just curious. I mean, I guess that's the only thing it can be, huh?
Well, I don't know. It's a very good question. I'm not 100% sure it's perfluoron because the eye is full of perfluoron, but it also has some BSS, right? Where we had them both in there. We're going to air. We took out the BSS first, as you always try to do, but you can't like remove 100% of the BSS and then remove the perfluorocarbon. That doesn't work that way. So most of the eye has perfluoron, and there's not a lot of BSS, but there is some. So maybe it's not perfluoron. I don't know.
So Dean, did the view clear at all after you put the viscoelastic, or no?
Clear, but only for a few seconds, enough to take out a little more fluid, but then the view got lousy again. So what we did here is we angle the infusion towards the cornea, you know, towards the anterior chamber. Remember, it's an aphakic eye. You can zoom to the end. And what you then have to do, right there, yep, you could advance it, is you have to put another instrument in to withdraw the air that's in the AC. You could actually stop the video right here. So basically, you have a high vapor pressure, right? It's very humid in there, and whatever's condensing on the back of the cornea is impeding your view. So you can blow dry air through the infusion, because remember, we're on air, but you can't just do that. You also have to have an egress of air. You could also take out the cannula and have air come out the cannula, but now with valved cannulas, if you leave the cannula in, you won't have egress of air. So we then put the vitrector in and aspirate it in the anterior chamber so that you have a rapid flow of dry air coming in, air that's humid being removed through the vitrector, and that dry air replaces all the humid air in the eye. The vapor pressure goes back to normal, and you can continue the case. It won't fog up real quickly. It'll fog up again, but not in 5 seconds. It might take longer. So we were able to finish the case.
That's cool.
Never seen that before, Dean.
I've never seen that. That's not happening. I don't, you know, I was wondering, you know, did the eye get overfilled with PFO? Like, did it actually come up to the, but I can't imagine that happened. So yeah, it's very interesting.
I don't know, but the important thing is to have egress of the humid fluid. Okay, you can go to the next case. Nope, same one.
Yeah, no, I'm just, and so, yeah, this is one of your cases, Dean.
Yep, so young child presents with poor vision in the right eye. Count fingers at 3 feet, 20/20 in the left, as you can imagine. Optic disc pit with cirrus detachment. He's actually got 2 cirrus detachments. You see one at the fovea, but you also see one superior to the disc. Yep, best seen in those infrareds. And you can see the massive schisis changes. So in general, guys, what's your approach for this? He's 8 years old. What do you do for these?
Mike, go ahead first.
You know, so in these cases, I tend to try to, you know, do a very thorough vitrectomy, try to get anything that I see maybe on the disc that looks like there's traction changes around the pit, try to clear that up. I also try to peel, the reason that I would stain and peel in the macula is I just want to make sure that there's not any vitreous sort of traction there. And I think it can be hard to find that. In the past, I've used triamcinolone, just anything to help me get any kind of vitreous schisis membranes off of that. And then I do a fluid gas exchange, trying to flatten at least in the papillomacular bundle, and then just medium laser around the pit.
Okay, Gaurav, same thing?
Yep, same thing, yeah, same thing.
All right. So here's another eye normal. So here's the surgery. This case was video was edited by Cassie Ludwig, a recent fellow who is now at Stanford. By the way, the last case was edited by Marissa Tiger, one of our current fellows, who's doing a great job, not just in videos, but in surgery as well. So here you see, she's excellent at video editing, but even more excellent as a surgeon. And here you see creating the PVD. You can see a beautiful wave emanating outward. Nice wave of posterior hyaloid. Remember, he's 8 years old, so he's got a pretty adherent hyaloid. It was quite difficult to separate, but anyway, it separates really nicely. And what I like to do in these cases is all I do is separate the hyaloid, remove as much vitreous as safely possible, and then I do laser on the edge of the disc, and I do it before the fluid air exchange because the detached retina in the peripapillary region, well, I guess I forgot to tell you this, I also pick any fuzz that might be in the disc. In this case, there were a little epiretinal tissue that was in the disc. I try to alter the anatomy a little bit of whatever's going on in there. So we removed a little bit of fuzz that was stained with Kenalog. And then I laser around the disc because I think the papillomacular bundle is somewhat protected when you have some subretinal fluid there. And most of the people watching this webinar probably don't remember the days that we used to just laser CNVMs that were peripapillary, and they don't damage the nerve fiber layer. So you're going to be even more protected when you have fluid under there. So now we just do the fluid air exchange after we've lasered, dry everything out, and we're pretty much done. And you could see post-op pictures. You could just advance.
Yeah.
That this.
Oh, sorry.
Yeah, that's perfect. And you see the fluids at the top there, improving. You see the vision in the lower left. So now he's 2100 versus count fingers pre-op. Keep going. Now he's 2060 with less fluid, and you can see this is post-op month 15 when he's finally dry, kind of like your case, Mike. What's really fascinating about this is I don't do anything over the fovea, but what I had recently, the first time I've ever had this, not in this patient, in an adult patient, he was in his 30s, we did the exact same thing we did here, and he actually developed a macular hole. Had I peeled something at the fovea, I would have been mad at myself for peeling that I induced a mac hole, but I didn't do anything to the fovea. All I did was pop off the hyaloid, do exactly what I did here, laser, and do a fluid air exchange. And he got a post-op mac hole, which I had never seen before in one of these. But anyway, this patient did great. So advance another slide. I think we have one more, and we have a summary slide of the slow resolution. So any comments on this?
And it did not come back. So Mike and Dean, my question to you guys, Dean, do you ever, let's say fast forward, somebody's 40 years old and you can laser them in the office first before doing surgery. Any thoughts on that?
I have not tried that. I've heard people do it. I don't know, Mike, have you?
No, I don't. For whatever reason, I have not done a lot of schisis in these kind of cases, and so I don't really, the optic pit cases, I just don't have a lot of experience. But I would find it be quite difficult to get laser takes in where I'm pointing out right there pre-op, and so I guess after you release some traction.
On a case like this, it'd be hard, but I haven't done it myself, but I hear people doing this in the office and then seeing what happens afterwards. But maybe when there's less, when there's much less fluid, might be a good approach. But I think the lesson here, Dean, is it takes a long time for the fluid to go away, and it has not come back, which is great. So
yeah, and the ultimate question is, if I did nose surgery, would this fluid have eventually gone away?
Well, that's an important point about this because there's been talks given about inner retinal fenestration and other many different techniques. And anytime that there's a lot of different techniques for a surgery, for a surgical problem, that usually means that none of them work that great. But I'm kind of in the camp of less is more. And I think that this, this kind of procedure makes good sense to me. And so I like it, using TIS-seal in the pit and things like that. Those things can be reserved for reoperations, but I think something like you just did is probably the best good first method for trying to get this to close.
Well, and probably, Dean, it's not like you did this day one on the day you saw the kid. I mean, I'm sure this kid had been seen for like months with this.
Correct.
So
Many months.
You had time on your side to saying this is not going away. So
We definitely waited. That's a very good point. I'm glad you brought that up, because we don't jump into these, but he was getting worse. All right, I think we probably have time for one more short case.
One more?
2 minutes left. We can stop now if you want.
No, I think this is good. Please,
All right.
the more the better, merrier.
So this is a 37-year-old woman, had a MAC off RD. I did the case, buccal gas, and now go to the next photo. Oh, no, I didn't do this. Sorry, I thought we were showing a different case. No, this case was referred in, actually. Sorry. This patient was sent in for another opinion as to why the patient lost vision during surgery, post-op, okay? They did a normal buccal vit, and this is what happened. So you can see the disc is a bit pale in this right eye with the detachment. You go to the next slide. You can see the buccal's a bit on the high side, and now you can see the disc is really pale, right? The last photo showed sort of maybe pallor, but now it's obviously pale. So what happened here? The patient didn't have any pain the night of surgery, according to her. The surgeon said there were no issues. They don't think they got too much
block issue,
too much gas. Well, the block is concerned. Could have been the block, right? Is there another slide, or is that it? Yeah, okay, a couple more slides. Yep. You can see where the old attachment was. Looks like a couple demarcation lines in the right eye. Next slide. Yeah, you'll see a thinned retina on OCT. So obviously there's some sort of vascular compromise of the disc and or the retina. And what was it? Is it the retrobulbar block? I mean, this patient was not under general, according to the op notes. So they did a block. I do peribulbars. I never do retrobulbars, but I think this eye did have a retrobulbar. So Gaurav, maybe it was the block. Maybe the gas mixture, right? The patient had too high pressure the evening of the surgery. Or maybe during the surgery, the blood pressure was too low in the patient. Sometimes in patients under general, I said this patient wasn't under general, but sometimes under general, they run the patients with really low BP. And you can actually get a problem if the blood pressure is too low and your eye pressure is too high, especially when you're putting on a buckle and somebody's pulling on the strings and the eye's optic nerve is compromised. So any other thoughts as to why this happens? But, we get these as additional opinions and we dread that this would happen to us. But, many times we don't know the cause. And that's why we dread it even more, because the fear that this can happen to one of us is out there. And we don't always know what caused this. It'd be different if the patient had pain the evening of the surgery. You'd say, well, maybe the gas mixture wasn't proper. I mean, I always mix my own gas. I don't know what they did. Any other comments about this type of horrible outcome that we all fear?
Perfusion pressure, Dean. I'm with you. Perfusion.
So you think it's often the systemic blood pressure that's too low? I always tell the fellows one thing. A lot of times they're peeling a membrane and all of a sudden the nerve starts pulsating. And I say to the fellow, what are you noticing? And invariably they're focusing on the membrane. They're not even noticing that the disc is pulsating. I'll say, okay, disc is pulsating. What does that mean? And a lot of times they'll say, oh, lower the pressure from 20 to 15 or 10. That's correct. But you also have to ask, what is the systemic blood pressure? Because many times, I'm not kidding, many times it's like 90/40. They don't know why the anesthesiologists do this.
That's right, Dean. You usually see like 88/50, right? It's like, that's a problem.
Mike, you were going to say something?
Yeah, I think in the early postoperative period, a patient's blocked. They may be vagal, nauseated, hypotensive. The pressure may be pretty high at the end of the case from the buccal, and just a lot of times, when people are doing these cases, they have the option, they could tap the anterior chamber after they're finished with the buccal procedure or not. and they decide not to, and they look in there and there's pulsatile flow, but then they go to recovery and their blood pressure goes down, and I think they can have an artery occlusion of cap in over just hours that can cause you to have a pale nerve. And but usually you'd see some pallor to the retina. You'd see other signs of a central retinal artery occlusion. So I do worry about this kind of case being a block related complication, although it's very difficult to prove that and understand. You can try to get an MR of the orbit and see if you can get a sheath and look if there's a sheath hemorrhage or something, but it's a hard thing to figure out.
So another case was sent to me recently, a great surgeon, and what you brought up, an interesting thing, Mike, vasovagal. The patient that also lost vision, the new patient I'm telling you about was just a vitrectomy. It was not a buccal vit. And the patient actually had a vasovagal event when the anesthesia was trying to put in the IV. So presumably the blood pressure maybe remained low during the surgery. And that's why that patient had the same thing happen, right? Because most patients don't get vasovagal before the surgery, but that was an uncomplicated pucker, a short case. The pressure never went up in the eye and no buccal. And maybe it was the vasovagal event prior where the patient was just predisposed to some low blood pressure and maybe got post-op low blood pressure. So you both bring up really good points with the block, the blood pressure, maybe the gas bubble. I mean, these are scary things.
So Dean, to add to the scare, you and Mike, we'll be presenting this at the Duke meeting, but at OMIC, we in the last 3 years, which is just shocking to me, we've had about 13 to 14 cases of wrong gas mixtures that have led to horrendous outcomes in the eye. And in this day and age, it is just, these were eyes that were 2015 gone to NLP, right? And the problem is, as both of you guys know, it can happen, but there's safeguards that we can all do to make sure to decrease that risk to almost zero. And I think what happens is now we have people who are not trained in the OR, like maybe so many years ago. You have staff, understaffed, people are tired of the end of the case. And, like a pilot does a checklist at landing and, taking off. And I think we do a good job of a checklist in the beginning of surgery. But at the end, I think people are ready to sometimes move on to the next case and so on and so forth. And it's a sort of problem that shouldn't happen in our profession. 15 cases of wrong gas mixtures in 3 years, that horrendous outcomes.
So do you guys mix your own gas?
Yes.
I typically do, or I will be next to the circulator as she's actually doing it with me there.
Yeah, I actually mix it while those fellows at the head of the table, I'll mix it. And I always confirm with the fellow.
Exactly.
I push the plunger down to, if I'm doing 14%, I push it down to 7 and I show it to the fellow, say 7, fellow agrees to stress the point that this should always be checked by somebody else to confirm that we're doing this. So,
I always have the lights on, Dean. Yeah, I hate when people are mixing gas when the lights are off. And then if I know it's a macular hole case, I'm going to use 20 or 25% SF6 or what I'm going to use. On the whiteboard, I write down what percentage I want. So I said, let's look at the whiteboard, and that's the percentage we want unless I change my mind. But I kind of have it written, that's what we want.
Yeah, it's good. So it sounds like all three of us are super compulsive about this. And those of you watching, please do the same, because Gaurav, you're telling me that a lot of cases had wrong gas mix. That's,
I mean, in 3 years, Dean, and the thing is, these are just reported as malpractice, right? It with just one carrier. It would be like, how could we in our profession have, it would be like having 15 eyes on the wrong eye surgery, right? Just can't happen.
Yeah, I always say there's enough reasons we can get sued. Don't give them one of the easy ones.
A couple of comments. One is, I wonder if that number has gone up as a result of traveler nurses and a lot of staffing issues and things.
100%.
I certainly, we've seen that around us. And then the other thing is that, I guess you really don't know where your injection is going. It's one of the, doing an anesthetic injection for a case. That's one of the blind procedures that we really do, where I don't know exactly where things are. When I'm doing any other procedure, I really kind of see where the instrument is, and the needle I don't really see. And so I tend to try to do a peribulbar block, like Dean said, but I also document that I've done a peribulbar block. If you were to take this case to somebody and it said that you had done a retrobulbar block, you know, that is, you know, an easy thing to point to that is a cause of this. And there was a time when I was doing cut downs and just using a blunt cannula to give my patients retrobulbar anesthesia, which I think works very well. But in the day of you know, sutureless surgery and trying to avoid making the conjunctiva blown up while I'm doing a 25 gauge vitrectomy, I've kind of gone away from that. But it's something worth thinking about doing, because I think it's a great way of giving anesthesia, and it's also safe.
And you know, Mike, the problem with that what you're described is, and sometimes you get ballooning and the contact lens doesn't stay on there. You know, it's just a pain. So I know it's 9:00, or I guess almost 10:08. So I know we want to try to wrap it up. So maybe one last comment from each one of us. I'll start with Mike and Mike first, and then Dean. You know, the title of this, what do you do? So Mike, real quick, when bad things occur, a couple of principles for the fellows to learn, just some salient words from Jumper that I would like for them to hear. And then Dean, and then I'll finish it off.
So a couple of things, you know, when we're talking about trying to prevent injury inside the eye when we're operating, which, you know, let's just step back and take a look at what we're doing. We're working and doing very intricate, you know, maneuvers in a space that's maybe, you know, 2 centimeters from front to back, that we've got to work within, you know, 500 microns is a huge distance when we're working. And so we're peeling membranes that are 7 micrometers, you know, thick and things like that. So I want to just you appreciate how intricate and difficult this is. And then what I try to stress with the fellows is a ready position. I want them to have a position where their instruments are in the eye that's safe, that they always go to if anything changes. The patient moves a little bit, a cough, they hear something, they just go to the ready position. They don't rip things out of the eye, they go to a ready position. I think that that is a good first step that we work on with the fellows to help make sure that they are safe in the eye, and then progress towards, you know, having these very difficult maneuvers to get really safe and good at. And it takes a while. And one of the things that you're going to learn is that when things go wrong, those initial learning points really start coming back, like going to 60 immediately when you worry that there's bleeding going on, getting to a ready position, you know, things like that I think are very important to do in these tough situations, so that you can think through how you're going to next handle the situation. And just ripping the instruments out of the eye isn't always the best case.
Dean?
Since Mike focused intraoperative, great comments, I'll focus preoperatively. So it's important to be prepared. The fact that you people are watching this webinar means, you know, you're not the surgeons anybody has to worry about. You're obviously very interested and you're learning things that will serve you well. And the solution for surgery is just to talk things over with your colleagues. I am constantly talking about things with my fellows and my colleagues because I learn something every single day. And if you're prepared when you go in the OR, you know, if this happens, I'm going to do the following. You know, you'll get there with experience, and it's going to be really nerve-wracking at the beginning. But you know, you people probably don't realize how good you are. You're all really smart. You matched into retina. You're at great programs. You're paying attention to seminars and other things. You go to meetings. I just looked at the attendee list. I mean, I recognize every single name. I mean, you know, you people are out there, and that's a good sign. That means you're present and you care about the results for your patients, and you want to do a good job. And just communicate with your colleagues. Your colleagues will teach you an unbelievable amount over the years. Nobody gets where they are as an island. You need people to help you out. So I'm asking my colleagues all the time what they do in different situations. And I think the future bodes well for you folks, because you're all interested and serious people. That's good. That's the way surgeons ought to be.
Well, thank you, Dean. And I would just say, you know, we talked about the preoperative, intraoperative. I'm not going to talk about the postoperative period, but I do think it's important to let patients know and let patients trust you, right? If the patients trust you and things have happened intraoperatively or so on and so forth, as we've shown, just be honest and tell them that you're not going to neglect them, right? And then you're going to try to get the best outcome possible. And when bad things do occur, when things are happening so fast, I would say emphasize what Dean and Mike says also is you need to slow down, right? You need to slow down and see what's happening. And so when things are happening fast, people want to go faster. That's the wrong thing to do. You got to slow down, compartmentalize the problem, and then fix it one step at a time. And just be honest with your patients, and you'll be amazed of what patients will sometimes feel bad for you that a complication unfortunately occurred. So just have your patients trust you, and that will take you a long way. So that's all I have to say. So, and trust your colleagues. Like Mike and Dean and I have been friends for so many years that we learn from each other, and each other's highs and lows. So kind of learn from that. So Monica, thank you so much.
Including tonight. Thank you.
We went 13 minutes over, but thank you to D.O.R.C for always supporting this and education, and thank you so much.
Thank you for a wonderful presentation this evening. For those of you who would like to watch the recording of tonight's video or any other previous Retina Connects, you can go to the Dutch Ophthalmic Research Center YouTube page to find those videos there. Have a great evening, and thank you for joining us.